আমরা শুরু করতে পারি, হ্যাঁ?
জি স্যার, আমরা শুরু করতে পারি।
ওকে। Good evening, everybody. Welcome to National Heart Foundation cardiac course for postgraduate student. This is our lecture number 48. Today our topic is ST elevation MI, clinical feature, diagnosis and complication. Today as panel of expert, Professor S.M. Mustafa Jaman has joined with us, and our today's speaker, Dr. Farhad Jamal. Farhad Jamal is the assistant professor and consultant cardiologist, National Heart Foundation Hospital and Research Institute. And the other speaker is Professor Dhiman Boni. He's the professor and senior consultant cardiologist, National Heart Foundation Hospital. Today, moderator was Dr. Tawfiq Shahriar Haq. He will join after some time. By this time, just I like to introduce and start the program. So welcome, Dr. S.M. Mustafa Jamal. Welcome our speaker, Professor Dhiman Bonik and Farhad Jamal. And welcome all the audience and my respected teachers. Dr. Farhad Jamal will be talking on diagnosis and clinical feature of ST elevation MI. And Professor Dhiman Bonik will be talking on complications of STEMI. So this is a very important topic. STEMI is a very important topic in the era of COVID because part of the treatment, especially primary PCI, is almost selectively done in most of the hospital. Very selectively it is now practiced, and mainly invasive, non-invasive, pharmaco-invasive therapy is primarily practiced in most of the hospital. And I like to request our speakers to start their speech. First, I like to request Dr. Farhad Jamal to share his slide and talk on his topic. And after the first talk, I will request Professor Mustafa Jaman for his valuable opinion regarding, as a part of examiner's perspective, his opinion and his advice to the fellows and students. Dr. Farhad Jamal.
Assalamu alaikum. Good evening to all my colleagues, my teachers, my dear moderators and panelists. My today's topic is STMI, clinical features and diagnosis. STMI represents the most lethal form of MI, which is completely occlusive, thrombus results in total cessation of coronary blood flow and manifests electrically as elevation of ST segment on ECG. If we go to the clinical features encompasses a lot of things: typical signs, symptoms, the risk factors, atypical presentations, clinical features of complication, and of course, atypical features with high index of suspicion. What are the risk factors? There are some modifiable risk factors, some modifiable, some emerging risk factors. Gender, age, female, family history of cardiovascular disease, diabetes, these are non-modifiable risk factors. And among the modifiable risk factors, smoking, poor diet, dyslipidemia, physical inactivity, high blood pressure, overweight, depression, social isolation, these are modifiable. And there are some emerging risk factors also, like lipoprotein A, high lipoprotein A, apolipoprotein B, homocysteine, fibrinogen, etc. Clinical features of STMI. It is maybe due to features of sympathetic activation like pallor, sweating, tachycardia, features of vagal activation like vomiting, bradycardia, features of impaired myocardial function like hypotension, oliguria, cold periphery, narrow pulse pressure, raised JBP, third heart sound, lung crepitation. There may be features of tissue damage like fever and features of complication like murmur in VSR or mitral regurgitation and pericardial rub. In history, patient with typical acute STMI usually presents with chest pain and may have prodrome symptoms of fatigue, chest discomfort, or malaise in the days preceding the event. Alternatively, typical ST segment elevation may also occur suddenly without any warning. Typical chest pain in acute STMI that have followed the following characteristics. It is intense and unremitting for last more than 30 to 60 minutes, may not related to exertion, substernal and often radiates to the left arm, but may also radiates to the lower jaw, neck, right arm, back, and upper abdomen. Usually described as substernal pressure sensation that also may be characterized as squeezing, aching, burning, or even sharp pain. In some patients, the symptoms in epigastric, which is a feeling of indigestion or fullness of and gas. Chest pain similar to a previous heart attack is also suggested. These are the scripted diagram showing the sites of myocardial infarction, which patient may feel in different sites, typical and atypical sites. Okay. Patient may not recognize the chest pain. Patient may not recognize the chest pain if there is high pain threshold or have a disorder that impair the pain perception, like diabetes mellitus. And patient may have no recollection of recent symptoms and may have no complaint even in elderly patient or in patient with pre-existing altered mental status or dementia. Some patient may have an altered mental status caused by impaired cerebral perfusion also. A high index of suspicion of myocardial infarction should be maintained, especially in women, diabetic patient, older patient, patient with dementia, patient with history of heart failure, cocaine users, and patient with positive family history for early coronary disease. Myocardial infarction most often occurs in the early morning hours. Why? The morning increase in the sympathetic tone, the morning increase in the blood viscosity, coagulability, and platelet aggregability, the increased morning level of serum cortisol and plasma catecholamines. Here is the schematic diagram showing how patients feel in case of ST elevation myocardial infarction. Other symptoms of myocardial infarction often includes the following: anxiety, commonly described as sense of impending doom; lightheadedness with or without syncope; cough; nausea with or without vomiting; profuse sweating; shortness of breath; wheeze; rapid or irregular heart rate; fullness, indigestion or choking feeling. The patient may recall only an episode of indigestion as an indication of myocardial infarction in some atypical cases. What are the signs? The patient's vital signs may demonstrate the following in case of MI. The pulse may be rapid, irregular, or slow, even slow, because of tachy or bradyarrhythmia and conduction defect. Blood pressure is initially may be elevated as an adrenergic response to pain and ventricular dysfunction. But in right ventricular myocardial infarction or severe left ventricular dysfunction, hypotension and cardiogenic shock can occur. The respiratory rate may increase in response to pulmonary congestion or anxiety. Levine signs is a typical sign where a person localizes the chest pain by clenching one or both fists over his sternum. This classically been thought to be a predictive of cardiac chest pain. Temperature, fever may occur easily in the first 24 hours to 48 hours due to tissue damage. Neck pain may be some characteristics present in acute inferior myocardial infarction or with right ventricular involvement, distension, systemic venous hypertension, edema, and hepatomegaly may present. Examination of the heart rate may often increase. Paradoxically, splitting of second heart sound may reflect the presence of left bundle branch block or prolongation of the pre-ejection period with delayed closure of the aortic valve. A pneumatal regurgitation murmur, typically holosystolic near the apex, indicates papillary muscle dysfunction or rupture. A holosystolic murmur that radiates to the mid-sternal border and not the back, possibly with a palpable shield, suggests a ventricular septal rupture. A pericardial friction rub may be audible as in to and fro spring sound in the and is produced through sliding contact of inflamed rough surfaces. Examination of the chest, there may be rales or wheeze on auscultation, and there may be secondary to pulmonary congestion. Unilateral or bilateral pleural effusion may produce diminished bronchial sound at the lung base. Even from the abdomen, in case of tricuspid incompetence, hepatojugular reflux may be elicited. A pulsatory abdominal mass may suggest an abdominal aortic aneurysm as an etiology. Examination of the extremities, there may be peripheral cyanosis, edema, pallor, diminished pulse volume, delayed rise or delayed capillary refill may indicate vasoconstriction, diminished cardiac output, and right ventricular dysfunction or failure. Diagnosis of ST elevation myocardial infarction. A working diagnosis of ST elevation myocardial infarction is usually based on symptoms and signs consistent with myocardial ischemia, there is persistent chest pain with a 12-lead electrocardiogram. A myocardial infarction according to current consensus is defined by the elevated cardiac biomarkers with a rising or falling trend and at least one of the following symptoms related to ischemia, ST segment elevation, new left bundle branch block, changes in the motion of the heart or while on echocardiography, and demonstration of the thrombus on coronary angiogram or at autopsy. What are the objectives of laboratory tests? To determine the presence or absence of myocardial infarction, to characterize the location, the extent of myocardial infarction, to determine the recurrent ischemia or myocardial infarction, to detect the complication, and to estimate the patient's prognosis. Electrocardiogram is the hallmark in the diagnosis. It is the most important tool in the initial evaluation and trials of ACS. And European Society of Cardiology recommend the ACS should be done within first 10 minutes of first medical contact. And ECG only confirms the diagnosis in more than 80% of the cases, but also helps to detect the life-threatening arrhythmias and also early and prompt defibrillation therapy is if indicated. As per guideline, it is said that 12-lead ECG and interpretation should be done at the point of first medical contact within 10 minutes. ECG monitoring with defibrillator capacity is indicated as soon as possible in all patients with suspected STMI. The use of additional posterior lead in present with high suspicion of posterior myocardial infarction, that is circumflex occlusion. The use of additional right ventricular leads, that is V3R or V4R in patients of to diagnose RV infarction. And blood sampling, routine blood sampling is indicated as soon as possible in the acute phase, but should not delay reperfusion treatment. So clinical features, suggestive and ECG that are sufficient to initiate the treatment. What are the ECG criteria? At least 2 contagious lead with ST segment elevation 2.5 mm in men less than 40 years, or 2 mm in men of more than 40 years, or 1.5 mm in women in lead V2 to V3 and or 1 mm in the other lead, in the absence of left ventricular left bundle branch block. In patient with inferior MI, it is recommended to record right precordial lead, that is V3R or V4R, and V7 to V9, seeking ST segment elevation to identify concomitant right ventricular infarction and posterior myocardial infarction. These are the ECG change that with timeline. Initial lead normal, then peaked tall, peaked or hyperacute T. There is progressive ST segment elevation, minutes to hours, loss of R wave and Q wave formation, it is hour to days, and T wave inversion in over days, and T wave normalization, persistence of Q wave over days, weeks to months. This is the ECG of acute STMI anterior, anteroseptal, sorry. And this is the ECG of acute ST segment elevation MI inferior. What is Garbosa criteria? In presence of left bundle branch block or in paced rhythm, there is difficulties in the diagnosis of STMI. It is said that the 3 criteria are used here in this case in LBB. Concordant ST segment elevation 1 mm, more than 1 mm in leads with positive QRS complex. The score will be 5. Concordant ST depression more than 1 mm in V1 to V3, that is score 3. An excessively discordant ST elevation 5 millimeter, more than 5 millimeter in lead with negative QS complex, that is score 2. A total score of 3 or more has a specificity of 90% in the diagnosis of myocardial infarction. Mind that this is for diagnosis of STMI in the setting of pre-existing LVV. But new onset LVV itself is a diagnostic criteria. What is ischemic distance in ECG? Sometimes we may found in ST depression in some other leads, which may represent acute ischemia due to coronary artery disease in non-infarctated artery, or may represent pure mirror image of reciprocal change. And mostly this pattern is due to remote ST depression, reciprocal change, not due, it is due to reciprocal change, not due to ischemia at distance. ECG is very important, not only in the diagnosis, but also helps in the rapidity of revascularization, especially in case of inferior wall myocardial infarction, and also it helps in the risk stratification. As for example, inferior MI may occur in both LAD, RCA, or LCS occlusion. So, which artery is the culprit? That is important. So for the determination, especially when there is lesion in both artery, we found, or which artery we should first canalize. Features favoring the RCA as a culprit lesion are ST elevation in lead 3 more than lead 2, ST depression in AVL is more than ST depression in lead 1 with ST depression more than 1 millimeter in lead 1 and AVL. Presence of right ventricular myocardial infarctions as suggested by ST elevation in V3R or V4R, and ratio of ST depression in V3 to ST elevation in lead 3 less than 0.5. All this suggest right coronary artery as a culprit lesion. Secondly, we can also categorize as presume whether it is proximal right coronary or is distal right coronary, because complications and necessity of urgency that also varies in. If it is proximal coronary, there is high chance of RV infarction and arrhythmia and conduction defect. In case of proximal infarction, proximal RCA occlusion, there may be RBMI, and ratio of ST depression in V3 to ST elevation in lead 3 will be less than 0.5. Whereas in mid or distal RCA occlusion, there will be reciprocal ST depression in V1 to V2, and the ratio of ST depression in V3 to ST elevation in lead 3 will be 0.5 to 1.2 millimeter of mercury. Sorry, millimeter. What are the features that suggest LCS occlusion? There are lots of criteria, but two criteria important: ST segment elevation in lead 3 less than that of lead 2, and ratio of ST depression in V3 to ST elevation in lead 3 more than 1.2. These two criteria is very sensitive for diagnosis of LCS as a culprit artery, whereas ratio less than 0.5 is in case of proximal RCA. In case of lead V4R, it also helps in the diagnosis. If there is ST segment elevation with positive T wave, there is proximal RCA occlusion. If there is no ST segment elevation but positive T wave, there is possibly distal RCA occlusion. If there is ST depression more than 1 millimeter with negative T wave, that is LCS occlusion. It is in V4R. What in case of posterior wall myocardial infarction? It's already said ST segment elevation more than 0.5 millimeter in lead V7 to V9. That is one criteria. And another criteria is tall R in V1 with ST segment depression in V1. That is mirror image change in V1. That is also a criteria. And it is said that pure posterior myocardial infarction is a predictive of LCS occlusion. Several ECG criteria has been reported to indicate a LAD artery occlusion that is proximal to first septal perforator. That is very high proximal and is a notorious condition. What are the changes? ST segment elevation in lead AVR, right bundle branch block, ST depression in lead V5, ST segment elevation in V1 more than 2.5 millimeter. And this is the ECG change that indicating occlusion before the first septal perforator. What is the change that occurs if the occlusion occurs before or after first diagonal? If it is occurs before first diagonal, ST segment elevation in V1 to V3 and AVL and AVR with ST segment depression 1 meter or more in inferior lead and V5. Whereas if it is after first diagonal, inferior wall ST segment depression will be absent. So in the bottom line, there's another thing regarding simultaneous acute inferior myocardial infarction and anterior ST elevation myocardial infarction that may present in 15% of the cases, which may be due to two cases. RC, whether we are in dilemma whether it is RC occlusion or type 4 LAD occlusion, which wrapped around the posterior crux. What are the clues? ST elevation in lead 3 more than 2 suggests proximal RC occlusion. ST elevation in lead V1 more than V3 suggests proximal RCA. Or if the progressive ST elevation is there is from V1 to V4, that suggests a wrapped round or type 4 LAD. Left mid stenosis is predicted by ST segment elevation in lead AVR or marked ST depression in 8 or more lead. In case of atypical ECG finding, if there is a doubt, echocardiography is recommended for initial diagnosis. If echocardiography is not available or if doubt persists even after echo, a primary PCI strategy is indicated, including immediate transfer to a PCI center if the patient is being treated in a non-PCI center. And this is the graph showing that it is 10 minutes, within 10 minutes, the ECG should be done after first medical contact. And if transfer is possible within 120 minutes in a PCI capable hospital with the intention of primary PCI, then patient should be transferred instead of giving fibrinolysis. Regarding cardiac biomarkers, American College of Cardiology, CCAHA, and ESC guideline recommend cardiac troponin as the only cardiac biomarker that should be measured at presentation in patient with suspected myocardial infarction due to superior sensitivity and accuracy. And troponin I is a contractile protein that is not normally found in serum and is released only when myocardial necrosis occurs. At least one value of high sensitive cardiac troponin should be above the 99th percentile of upper reference limit. Serum level increases within 3 to 12 hours from the onset of chest pain, peak at 24 hours to 48 hours, and return to baseline over 5 to 14 days. Serum measurement of cardiac troponin is obtained at presentation 3 to 6 hours after symptom onset. If initial level is negative, initial measurement beyond the 6 hours should be obtained because serum measurement is very important. This is the time frame, a graph showing the time frame, showing that troponin I, CKMB, and LDH other levels. It is so seen that CKMB raised very rapidly and comes towards normal also rapidly. So it is useful in diagnosis of the reinfarction. More important. Okay. What are the other lab tests? These are actually supportive lab tests. We should not wait for this test, even not for troponin I, for the treatment strategy. What is this? Complete blood count. Obtain a complete blood count in order to rule out anemia as a cause of secondary MI. That is demand supply mismatch, decreased oxygen supply. Leukocytosis is also common but not universal. The leukocytosis usually starts at 2 hours and peak within 2 to 4 hours. As polymorphonuclear leukocytosis usually occurs. Other routine lab tests that we do, lipid profile may be helpful if obtained upon presentation because level can change after 12 to 24 hours of an acute illness. Blood sugar, hemoglobin A1C, serum creatinine, SGPT, serum electrolyte, complete blood count that I have already said. Regarding cardiac imaging, the role of cardiac imaging in the working up of acute myocardial infarction is broad, but the procedure are primarily used to confirm and rule out coronary artery disease. Furthermore, imaging may help to determine the anatomy and degree of myocardial perfusion abnormality. Echocardiography, if I've already said, it is if there is doubt in regarding the possibility of acute evolving myocardial infarction, echocardiography is recommended. It is highly recommended and is required to evaluate ventricular function. Pulmonary motion abnormalities also used to define the pericardial effusion, ischemic mitral regurgitation, cardiac tamponade, ventricular septal rupture, which that may complicate acute myocardial infarction. Chest X-ray may show features of acute pulmonary edema. Coronary angiogram with the aim of primary PCI is done. It is recommended in recommended time frame with the aim to primary PCI in primary PCI capable hospital, and transfer to a primary PCI capable hospital in the time frame is required based on the angiographic result, patient comorbidities, and subsequent treatment is recommended. That is primary PCI or urgent cardiac CABG surgery. The slide I have already shown. There are some other tests, but these tests are done in post-MI stable cases. These are not helpful, hence not recommended in acute STMI. They are helpful in post-MI stable cases for restoration decision making. That is stress echocardiography, treadmill test, scan using radioactive contrast. What I have already said, all these are mostly due to spontaneous myocardial infarction. As per universal definition of MI, myocardial infarction are of 5 types. If it is due to PCI, then it is said that troponin should be raised more than 5 times of 99 percentile of with new onset of STT change or LVV or angiographic loss of patent coronary artery. If it is related to the stent thrombosis, there is rise or fall or troponin I with documentation of this thrombus by coronary angiography. If it is due to CABG surgery, post-CABG surgery, acute myocardial infarction, in that case, troponin should be raised 10-fold of above the 99 percentile of normal with new onset of ECG change or abnormal change in new loss of myocardium viability and new changes in graft vessel patency. That's all. Thank you very much.
Thank you, Dr. Farhad Jamal, for elaborate speech on clinical picture and diagnosis of acute MI. And for the student, very important regarding the how will you diagnose the acute MI cases, especially what are the ECG findings, what are the biomarkers, and what are the time when you will do the ECG and subsequent follow-up ECG. The same is true for biomarker. Which one is most important, whether troponin I or CKMB? What are the other investigation that you will do? And other thing that is also frequently asked, ST elevation, how much ST elevation, 2 millimeter or 1 millimeter, anteriorly 2 millimeter, inferiorly 1 millimeter. If there is pre-existing LVV, what will be the diagnostic criteria? That is frequently asked, as well as what are the clinical features of anterior MI, what are the clinical features of inferior MI? That varies actually, because inferior MI mostly present with brady, sometimes complete heart block associated with anti-infarction hypotension. On the other hand, anterior infarction has got increased sympathetic activity related features. So that you should definitively remember. And universal classification of acute MI, I think that may be asked frequently, type 1, 2, 3, 4 like this. So I would like to request Dr. Mustafa Jamal for your comment, please.
Thank you. Yeah, actually, nicely presented by Dr. Farhad Jamal, and a lot of things, especially our students, they will be benefited from this, and a lot of questions already answered. Already, Dr. Ashok Dutt also mentioned. Especially, our students, they face this type of problem, especially in their residency program. Also, and suppose how to manage a patient with a chest pain in emergency department, or sometimes maybe a question like this in written question also, patient with complication of MI, maybe cardiac shock or with heart rate maybe 38, how we'll manage in residency program end of block test, or with maybe with MI with lot of problem. Many already Dr. Dhiman Bonik will present later, I think. But ECG recognition is very important, already mentioned by Dr. Farhad Jamal. If you diagnose the ECG, that will be very important, because without any other test, we can do the primary piece only by the ECG. We can do the other test at that moment. So for the treatment purpose, ECG is actually a very important tool for diagnosis of acute MI, escalation MI. And treatment purpose, actually a lot of things we can say. One is student level things. The guideline is giving us the time is reducing. Suppose already mentioned by Dr. Farhad Jamal, only 10 minutes. This is very important, but it's impossible some in our country. And the guideline of ESC, especially in primary PCI for less than 60 minutes in a PCI center, transfer of patient to PCI center is very important. We can do the time within the golden time, and the non-PCI center less than 120 minutes. So in our country, sometimes it need due to traffic jam and other things. So mostly patient arrived or delayed presentation. So that is another question. But for the student purpose, we can discuss many things. And in other things, in decision making, in case of primary PCI, multiple lesion or culprit lesion, Leishman disease, and sometimes patient with MI with septal rupture, a lot of things actually we can face, and we can say many things after maybe another presentation that will be better, because we can do a regional context guideline protocol based, because there are a lot of variation in treatment in our Bangladesh. Because one institution is, though guideline is right, actually very good sentence, but in primary PCI very limited, only 4 to 6%. Very few centers are doing primary PCI still now. So pharmacoinvasive therapy is very important. So we can discuss later after Dr. Dhiman Bonik's presentation. Thank you. If needed, I can add something after the Dhiman Bonik presentation. Thank you.
Sir, unmute.
Unmute, please.
Thank you, Dr. Mustafa Jaman, for your valuable opinion. We'll just request you after Dr. Dhiman Bonik's speech. Now I would like to Dr. Tawfiq.
I can add another thing, please. Actually, when the last year, actually, during the COVID period, we found some patients with, especially MI with COVID. But at that times, actually, we do not the primary PCI most of the time. But later, that was patient was diagnosed was COVID, but angiogram was revealed no lesion or any stenosis. But we thought that was due to maybe type 2 MI. So I don't know, have you any experience or any discussion in we will discuss later. I think that will be better.
Yes, thank you. Well, better we will discuss it later after Dr. Dhiman Bonik's speech. Now I like to request Dr. Tawfiq Shahriar Haq. He's a bit delayed because of some internet issue. Dr. Tawfiq, would you please moderate the rest of the session, please?
Thank you very much, Ashok sir, Professor Ashok Dutta sir, for standing up for me. Now, we are already running quite late. I would like to request Professor Dhiman Bonik sir to kindly deliver his speech on complications of acute myocardial infarction. Sir, your slides are visible.
Yes.
You need to go to the beginning.
First, yes, sir. Thank you. Yes, Tawfiq. Give me a time. Okay. Sorry. Okay. respected moderator, respected panelists, teachers, colleagues, and friends. Today, my topic is on complication of ST segment elevation MI. This topic is very common, and we all read this topic for the last, even for the many years, all of us, all the audience. I just want to recapitulate this topic again to you, with you. The early complications of ST segment elevations are the common complications. You all know it is disturbance of rate and rhythm, cardiogenic shock. There may be left ventricular failure, pulmonary embolism or infarction, rupture of interventricular septum, acute MR, and pericarditis may be there. The early definition of the early complication is the complication which arises within 7 days. In some authors have mentioned it within 5 days, but most of the authors have mentioned it within 7 days. Late complications are reinfarction, recurrence of arrhythmias, heart failure, Deslers syndrome, development of ventricular aneurysm, sudden death, and thromboembolism. Regarding the, I want to go to the individual topic now. Regarding the hemodynamic disturbances, routine assessment of a patient with ST segment elevations MI is monitor of the heart rhythm regularly, repeat measurement of the systemic arterial pressure by cuff measurement, and repeated auscultation of the lung fields for pulmonary congestion, that is commonly left ventricular failure, and measurement of the urinary output, whether the patient is in shock. Then the examination of the skin for the evidence of adequacy of perfusion of the different parts of the body, monitoring the oxygen level of the patient for labeling the hypoxemia, either patient has got hypoxemia. If a patient in ST segment elevation MI has got heart failure, the assessment of hemodynamic compromise is very important. The central venous pressure reflects more for the right ventricular function rather than the left. Right ventricular function, there is systemic venous pressure may be normal. When a patient with right ventricular failure occurs due to RV infarction, the patient may exhibit elevated right atrial pressure and elevated central venous pressure, despite the patient has normal LV function. A low level of RA pressure and a low level of central venous pressure implies that the patient is in hypovolemia. Elevated RA pressure in a patient with ST segment elevation results from right ventricular failure, secondary to left ventricular failure, or pulmonary hypertension, RV infarction. There may be severe tricuspid regurgitation, or patient may be in pericardial tamponade. This is the slide for indication of patients with ST segment elevation where hemodynamic measurement should be performed meticulously. Whether the patient is in shock, if there is ventricular septal rupture, severe cardiogenic shock caused by right or left ventricular failure, refractory ventricular tachycardia, assessment of a patient with cardiac tamponade. These patients should undergo meticulous hemodynamic monitoring. This is an important slide of assessment of a patient with ST segment elevation MI clinically and by invasive monitoring. Clinically, if it is known as KILIP classification, you all know, it is if there is presence of Krebs or Ralphs and presence of S3. F3 is absent. This is type 1. If there is Krebs and S3 gallop is present, it is type 2. And if there is frank pulmonary edema and the patient is in shock, it is type 4. There is other important classification, invasive classification, by monitoring the pulmonary capillary waste pressure and by measuring the cardiac index, doing a central venous line. It is the if the patient is a pulmonary congestion and there is peripheral hypoperfusion and the normal cardiac index is 2.5 liter per minute square meter of body surface, and if it is less than 2.2 and the pulmonary capillary waste pressure is more than 18, then the patient is in type 4 heart failure. And this patient in both Killip and Forrester classification, if the patient is in type 4, then mortality is about 45 to 55% in both of this classification. This is a hemodynamic, normal hemodynamic hemodynamics of the different chambers of the heart. This normal RA pressure is 0 to 6, RV pressure is 25 systolic and 0 to 6. For normal PA pressure, you all know, 25 to 0 to 12. Pulmonary capillary pressure is 16 to 12, and cardiac index I have already mentioned. In patients with acute MI with LBF, these patients will have normal RA pressure, and the RV pressure, systolic pressure will be raised. The pulmonary capillary waste pressure will be raised more than 18, and cardiac index will be up to not more than 2.22 liters. And in patients with RB, in patients with pulmonary embolism, you can see the RA pressure, and in the patient with RB pressure will be raised, and PA pressure will be raised, and pulmonary capillary pressure will be decreased, and also decreased of the cardiac index. Now about the left ventricular dysfunction is one of the most important predictor of mortality in case of ST segment elevation MI. There in ST segment elevation MI, there may be systolic or diastolic or both dysfunction may occur. The patient who are more prone to develop left ventricular failure are extent of the myocardial infarction, that is infarct size, advanced age, and in diabetes. In diabetes, patient has got diffuse disease, calcified lesion, and these patients are more prone to develop LBF. In ST segment elevation MI, hypoxemia may occur due to heart failure. There may be pulmonary vascular engorgement due to the pulmonary interstitial edema. There may be diminished vital capacity. Respiratory depression may occur from narcotic analgesic also, and this patient may develop hypoxemia or decrease in saturation of oxygen. Hypoxemia can impair the function of the ischemic tissue at the margin of the infarct and gradually increasing the infarct size. And this is the vicious cycle. As the infarct size increases, and this patient will more prone to develop hypoxemia and more ischemia of the myocardium. This is the vicious cycle. Now about the cardiogenic shock. Cardiogenic shock is characterized by the congestion and inadequacy of the tissue or end organ perfusion secondary to cardiac insufficiency. Cardiogenic shock complicating MI, in ST segment elevation MI, there is LV dysfunction is approximately in about 80% of patients. The remainder have 20% are mostly of different mechanical defects such as VSD, pulmonary papillary muscle rupture. This is the important slide of which patient will develop cardiogenic shock. Risk factors for cardiogenic shock, as usual, are older patient, diabetic patient, previous history of MI, that is, a patient has an inferior MI previously, now having an anterior MI. These patients are more prone to develop cardiogenic shock or both wall MI. And patient with heart failure, patient will develop cardiogenic shock after ST segment elevation MI. Anterior infarction. In this case, I have to mention for the students, there is a term which are the large infarct. Three are called the large infarct: anterior infarction, extensive myocardial infarction, and another is an inferior MI with posterior extension. These three are termed as large infarct. These large infarct are more prone to develop cardiogenic shock. In previously, 20% of patients of ST segment elevation MI develop cardiogenic shock. Blood in the recent clinical trials and observational data shows with prompt use of fibrinolytics and primary PCI, 5 to 8% of patients develop cardiogenic shock. With shock, the prognosis is very poor, and in-hospital mortality is about 40 to 60%. This is the graph showing the flow chart of a patient of developing cardiogenic after myocardial infarction. There is systolic and diastolic dysfunction. there will be decrease in cardiac output, hypotension will be there, there will be coronary perfusion will be there, coronary perfusion pressure will reduce, this produce ischemia, and in diastolic dysfunction occurs, this will produce LVDP increase, hypoxemia will be increased, this will cause ischemia, and there is inflammation in the after developing myocardial infarction, release of some interleukins which causes more ischemia, and this can be prevented by relief of ischemia and revascularization. The diagnosis of cardiogenic shock would be made by frank or relative hypotension defined by blood pressure, systolic blood pressure below 80 or 90 millimeter of mercury, or reduction of the mean arterial pressure of 30 millimeter of mercury, and cardiac index less than 1.8 liters without a mechanical support, or 2.2 liter with a mechanical support. And if elevated and diastolic pressure on the RV is more than 10 to 15 millimeter of mercury, and in the left side it is more than 18 millimeter of mercury, this patient is in cardiogenic shock. There are many other evidence of end organ hypoperfusion, such as altered mental status, decreased in cardiac output, if there is acute kidney injury after MI, this patient is in cardiogenic, or cold or mottled extremities, acute liver injury by increasing the enzymes of liver, or lactic acidosis. A patient with lactic acidosis is an important diagnostic and prognostic marker for cardiogenic shock. About cardiogenic shock, if a patient with ST segment elevation MI suddenly develop circulatory collapse, this patient should be evaluated for any mechanical complication, and this should be include a hemodynamic monitoring, angiographic evaluation, or an echocardiographic evaluation. As because if a patient develop mechanical complication, this patient should be dealt immediately, other than their mortality is very high. Right ventricular infarction, Dr. Farhad Jamal has widely mentioned. This slide is a common slide of us. Right ventricular infarction. In some books, it is written that a patient with inferior myocardial infarction, all patients should undergo for right-sided ECG. For these students, I want to mention here that the lead placement of 6 lead in right ventricular, V1 and V2 should as usual of the left, and V3, V4R should be changed, and V4R, V4-6R. This is the important slide or differentiate the topic. Dr. Farhad Jamal has mentioned this also, and the management of arrhythmia infarction will be detailed in the next clinical class of our class. Now the patients of mechanical heart failure. This is a slide of acute valve rupture of myocardial after ST segment elevation MI. There are 2 types of rupture. One is catastrophic rupture and other is subacute rupture. Catastrophic rupture suddenly develops cardiac tamponade and death, and subacute rupture may produce hypotension, heart failure, and pericardial tamponade. Risk factor of developing cardiac rupture are reperfusion with fibrinolytic agent, and it is less common in PCI, older age, female sex, hypotension. One important thing is that single vessel disease without collateral are more prone to develop septal valve rupture. And as usual, previously mentioned anterior MI or large infarct. This patient has got holosystolic murmur. If a patient of the ST segment elevation MI has a holosystolic murmur with a thrill, and ST gallop is there, pulmonary edema is there, this patient should be meticulously examined for an septal valve rupture. Mortality is very high, 75 to 90%. This is another slide of VSR, ventricular septal rupture. This is again commonly found in patients with lack of development of collateral network, advanced age, female sex, in patients with kidney disease. This here it is important that in case of anterior myocardial infarction, septal rupture is more common in the apical region. And in the inferior infraction, septal rupture is more common in the basal septum. And the basal septum rupture is most dangerous than apical septal rupture. Apical septal rupture is about 40 to 75%, and it also bears poor prognosis. This is another slide, mechanical defect of papillary muscle rupture. We all know there are two papillary muscle in the left side, anterolateral and posterior medial. It is important that posterior medial papillary muscle has a single blood supply, and it is from the RCA, dominant RCA or the dominant LCX. And the anterolateral muscle has got dual supply. So the posterior medial papillary muscle is more prone to rupture, and it implies that it will develop MR. And if there is a subsystolic murmur with no thrill and signs of volume, pulmonary edema and cardiogenic shock is there, this patient should be evaluated for papillary muscle rupture. Now the rate and rhythm disturbances, sinus tachycardia. This is a patient MI with sinus tachycardia. Management with precipitating factors. Beta blockers are commonly used, should be used, and classical beta blockers after ST segment elevations MI are metoprolol, atenolol, and bisoprolol. And if there is heart failure, carbidiol may be used. Among the rhythm disturbance, there is ventricular ectopics. If there is only ventricular ectopics per se, they do not need any antiarrhythmic therapy. Precipitating factor should be looked and managed. Acute management of pain and control of the heart failure and electrolyte balance should be normal. This is an important slide of an ST segment elevation MI, inferior MI, with, you can see in B4R there is ST segment elevation MI. So this has RB infraction with ventricular ectopic with compensatory pulse. Ventricular tachycardia occurs as a common the common complication of myocardial ST segment elevation MI. If there is non-sustained VT or duration of 30 seconds, managed with precipitating factors, and if antiarrhythmic drugs is used, amiodarone may be used. If a patient has sustained VT, then if patient is hemodynamically stable, then infusion with amiodarone. And in some case, where amiodarone is not available, lignocaine may be used with caution, but lignocaine has very high side effects. So these are now avoided if amiodarone is available. And if it is hemodynamically unstable with VT, then DC cardioversion should be done. And magnesium level should be evaluated, and it should IV magnesium should be given. This is an ST segment elevation MI, inferior MI with following VT. Now, if the patient develop ventricular defibrillation, treatment is immediate defibrillation. And some important points regarding VT and BF after ST segment elevation MI is patients with VT and BF had worse clinical outcome than those without VT and BF. The mortality rate is higher in those with late onset of VT-BF has less mortality than early VT-BF when compared without VT-BF. In patients who develop VT-BF develops later in the course after ST segment elevation, that is after 48 hours, this patient should be evaluated for ICD therapy for secondary prevention should be considered before discharge. In this situation, if the patient develops early VT-BF before reperfusion therapy, no antiarrhythmic other than beta blocker is indicated. Atrial fibrillation, many patients of acute MI develop atrial fibrillation. If the ventricular rate is less than 100 and systolic blood pressure is more than 90, and no treatment is required if the patient has no symptom. If the ventricular rate is more than 100 associated with systolic blood pressure more than 90, then beta blocker is the drug of choice. If the blood pressure is less than 90 and patient had got rapid ventricular rate, immediate cardioversion may be done. This is an ECG of a patient with anterior myocardial infarction with atrial fibrillation. We can see that irregular pulse with no P wave in V1 and lead 2. If now the patients with sinus bradycardia, if the heart rate is less than 40, sinus and the patient has rate-related symptom, bolus IV atropine may be given, and this will improve the heart rate of the patient, and it is more common in patients with inferior myocardial infarction. And if the heart rate persists and despite IV bolus of atropine up to 3 milligram, that is up to 5 ampule, then temporary pacing may be considered. This is an ECG of ST segment elevation MI in inferior MI with T inversion in V1 to V3 with sinus bradycardia. Other conduction defects such as a first degree heart block may be there. If a first degree heart block may be present in both anterior and inferior MI, if the patient has got no symptoms of bradycardia or no symptoms of bradycardia, then this patient may be closely observed without doing anything. Important is giving the patient beta blocker and non-dihydropyridine calcium channel blocker. If the peering interval is longer than 0.24 seconds, that is up to 6 small square, then the beta blocker should be reduced in dose. Other than beta blockers can be given in case of patients with ST segment elevation MI. This is an ECG of an inferior MI with first degree heart block with bradycardia. MOBIS 1 AV block. In MOBIS 1 AV block, if the patient heart rate exceeds 50 beats per minute and the patient had no PVC, heart failure or bundle branch block, patient should be observed. And if the patient has heart rate less than 50 and has symptoms of heart failure and bundle branch block, this patient should be might be treated with atropine up to 5 ampule. If the patient does not respond, then temporary pacing may be considered. This is an ECG of an inferior MI with MOBIS 1 type 2 AV block, that is progressive prolongation of the pre-air interval following by a drop. We can see there is a progressive prolongation of pre-air interval and there is following by a drop. MOBIS 2 and complete heart block, if the ventricular rate is less than 40 and the pause is more than 30 seconds and systolic blood pressure is less than 90, atropine should be given as usual. I have mentioned up to 5 ampule. If the rate does not increase, temporary pacing may be indicated. And in patients with anterior MI with MOBIS 2 and complete heart block, temporary pacing is indicated. This is an ECG of an inferior MI with a MOBIS 1 AV block. PP is equal and RR is equal and PR is also equal. You can see the PR interval in all the leads are equal. PP is equal and RR is equal. And this is the patient with complete AV dissociation. There is complete AV dissociation. PP is equal, RR are equal, and the PR is variable. Now this is now the important relation with interventricular block. Interventricular block, you all know that right ventricular, right bundle branch block and left posterior division of the left vesicle had dual blood supply and anterior by anterior descending artery and right coronary artery, and the left anterior division, that is left anterior division, has the single blood supply from LAD. So if the patient develop ST segment elevation, patient develop any forms of interventricular conduction block, they have higher biomarkers level, low ejection fraction, increase in hospital and long-term mortality. This is very important for a patient with ST segment elevation MI. These vesicular block are more common with anterior MI other than inferior or posterior MI. And the This is an ECG of anterior MI, anteroseptal MI with a left axis deviation, that left anterior hemiblock. You can see in 2, 3 and AVF, S is greater than R, and in 1 and AVL, R is greater, and the patient has anteroseptal MI. This is the ECG of ST elevation anterior MI with LAHB, left anterior hemiblock. Right bundle Brown block alone can lead to AB block because of it is often a new lesion associated with anterior myocardial infarction. And if a patient have, if an anterior MI patient have isolated RB infarction, as an isolated right bundle branch block, there are increased mortality risk in patients with in these patients. This is an important ECG of an ST segment elevation MI anterior with RBD with posterior left posterior hemiblock. You can see 2, 3 AVF R is more and 1 AVL S is greater. So there is left posterior hemiblock, RBBB is there, and there is anterior MI. So this patient has got anterior MI with bifascicular block. This bifascicular block I have early mentioned had high mortality, and this mortality is increased when there is also AB block is present. If this bifascicular block patient has developed first degree heart block, it is known as trifascicular block, and this trifascicular block has high mortality rate other than bifascicular block. Now the important issue is that after MI, the patient has recurrent chest discomfort. How this will be different? This has an important differentials, as because this may be due to infrux size extension, pericarditis. Their patient may develop pulmonary embolism, or there may be non-cardiac related complication. Ischemic causes should be considered when acute reocclusion of a recanalized of a stented vessel, mechanical or thrombotic occlusion of the side branch, or a distal vessel during an initial PCI when done, and or new ischemia in the non-infract related artery. Important diagnostic maneuvers are this patient should undergo repeated physical examination, repeated ECG. Repeated ECG change should be more in favor of ischemic origin, and assessment of in response to sublingual nitroglycerin. If the chest pain responds to nitroglycerin, then these patients are of ischemic origin. Now the important slide about the pericardial effusion. Effusions are generally detected by echocardiography. Effusion are more common in patients with anterior or lateral MI, large infarct, microvascular obstruction, greater LV dysfunction, no reperfusion. If there is no reperfusion, pericardial effusion will be more. Pericardial effusion in ST segment elevation MI commonly do not cause any hemodynamic compromise. The reabsorption of the post-infarction pericardial effusion is slow, with resolution often taking even several months to be abolished. And effusion does not necessarily indicate that patient has pericarditis, although they may be coexist with pericardial effusion. Most pericardial effusion develop without any evidence of pericarditis. In patients with pericarditis, pericarditis may be occur in patients with ST segment elevation MI as an early from the first day up to 8 weeks. This pericarditis may be confused with resulting from post-infarct angina, recurrent infarction, or both. The important distinguishing feature of an pericarditis is that the pain of pericarditis will be transmitted or radiates to the trapezius ridge of the patient, and it is the one of the pathognomic sign of pericarditis. And if there is presence of pericardial rub, which is best heard when the patient sitting and leaning forwards. The pericardial friction rub within first 48 hours in patients with may be found in patients with acute ST segment elevation MI. About pericarditis, other important is that if the pericarditis, when pericarditis is present and there is significant pericardial effusion of more than 10 millimeter, the anticoagulation in patients with ST segment elevation or after an primary PCI or any invasive procedure, this should be indicate of a discontinuation. Patients in whom continuation or initiation of anticoagulation therapy is strongly indicated after catheterization. Should have heightened the this clotting parameter should be monitored, and clinical observation should be done for possible tamponade. If patients with pericardial discomfort pericardial discomfort is spreaded, patients should be treated with aspirin but not with other NSAIDs or steroid, because this will improve the myocardial scar. This is an important slide of Dessler syndrome, which is also known as post-myocardial infarction syndrome, which occurs 1 to 8 weeks after myocardial infarction. This is associated with malaise, fever, pericardial discomfort, leukocytosis, and high ESR. And in autopsy, it is found that the fibrinous pericarditis with polymorphonuclear leukocytosis is there, and this indicates that this is the immunopathologic process, and this can be treated with aspirin 650 milligram every 4 hourly. But as usual, steroid and other NSAID should be avoided in Dessler syndrome. There's aneurysm. Aneurysm after ST segment elevation MI of 2 types. It is functional true aneurysm and pseudoaneurysm. In true aneurysm, there is scar formation after MI, and this causes aneurysm. And false aneurysm is that there is a hemorrhage from a small rupture of the ventricle, and this may have a mouth of aneurysm, and these are the pseudoaneurysm. Left ventricular failure with arterial embolization. Arterial embolization is also a common complication after ST segment elevation MI, and these are due to the endocardial inflammation and relative stasis of blood in the LV, and these thrombus are LV thrombus are in ST segment elevation after the gross antithrombotic strategy, recent times, and primary PCI. These have reduced from 20% to 5%, and these patients are more likely to develop increased mortality from complication of large infarct, shock, perfusion, rupture, and ventricular tachyarrhythmia, rather than emboli from LV thrombus. So lastly, a side of prognosis. In almost 1/4 of all cases of MI, death occurs within a few minutes without medical care. Half of the deaths of MI occur within 24 hours of the onset of symptoms. About 40% of all affected patients die within first month. The prognosis of those who survive to reach hospital is much better, with a 28-day survival of more than 80 days, 80%. Thank you all for patience hearing.
Thank you, Professor Dhiman Bonik, sir. Two very important topics were discussed by our favorite faculties. The most important thing here is that split-second decision-making can make the difference between life and death in these situations. So I know we have taken Professor Mustafa Zaman's very valuable chamber time. Sir, please make your concluding comments.
Thank you. So nicely discussed by Dr. Dhiman Bonik. Actually, every corner of completion of MI and discussed and by him very, very meticulously. Especially our junior fellows will be learned many things, and they will increase their learning curve, I think. And actually, from Dr. Farhad Jamal to Dr. Dhiman Bonik, they both have discussed everything. But I think for the student point of view, residents, actually, they have faced this type of problem. Suppose sometimes they know everything, knows everything. Suppose Dr. Dhiman Bonik will mention that some patients will face with different type of complication. But suppose one patient present with anterior MI with heart rate is 30 or with cardiogenic shock. So how will manage the patient? So this is sometimes they need, suppose temporary pacemakers, but in case of at that moment, they can't answer at that moment. But because all time they do not face this type of patient, and I think every phase B student should know how to do the temporary pacemaker, because it's life-saving actually measures. So they should know about the acute temporary MI with temporary pacemaker, how to pick a pacemaker procedure, and they should do at least few cases in case of in emergency situation. This is my opinion, because this is life-saving condition. Again, mentioned that sometimes uh, blood pressure is suppose low in case of acute LVF with MI. But when I ask our junior fellows or resident in block examination, how will manage or what that they do, they say many things, but all the things they do in same manner, that all the passion is same, but not they can't understand that the passion already given to him already. We have said that the patient's blood pressure is very low, so at that patient we do not mention that medicine that could below the blood pressure, suppose nitrates or other things, or in case of blood heart rate is low, we do not give the beta blocker. This is for the our learners. But Dr. Dhiman Monik actually mentioned everything. Nothing actually remained to discuss. But I want to mention another things because very, very important things. The RV failure, this is very, very important. And that should be recognized very, very important in case of acute MI. Sometimes we can do in echocardiography. That is very easy to detect the LV dysfunction. But the RV failure in case of with acute MI, this is very challenging. I think this should be discussed, and more every student should know carefully and meticulously. Then we can give the patient very good care to the patient, and we can save the life of patient. And thank you. I know everybody is actually everything is discussed. So thank you, Tawfiq, for giving time. Thank you, Dr. Dhiman Bonik and Farhad Jamal and Dr. Ashok Datto and Heart Foundation. They actually, I'm really honored to be here. And though it is chamber time, but I am really delighted to be here. Thank you, all of you.
Thank you, Professor Mostafa Zaman. I think there is a question, we can quickly take it. It's from Lieutenant Colonel Nizamul Hussain. I think Farhad, you can answer it. It says, do we need to do CKMB routinely with troponin I to diagnose acute STEM? Himan sir, would you like to take the question?
What is the question?
CKMB and troponin I both for acute MI?
No,
it is not, but both are not required. As for the guideline now recommend that the sensitivity of troponin I is and specificity is very high. So this troponin I is now used as a marker for myocardial infarction. C can be used for reinfarction, especially now for reinfarction diagnosis.
Okay, thank you very much. So I would like to request Professor Bodiuzzzaman sir, are you with us?
Thank you, Dr. Shahriar Hoque. I was listening to both the lectures. As you have mentioned, both the lectures are very important for the especially for the students. And regarding the exam, I think many questions will be asked from these topics to be discussed today, especially how to diagnose the MI and what is the complication, what is the management, immediate management of the complications. So I think it was all the points have been discussed very thoroughly by both the speakers. I think the students should go through the lecture again and again. Should put the video again. And thank you very much, Dr. Professor Dhiman Bonik and Dr. Farhad Jamal for both of you have presented excellently. And nothing more to add because already it was very detailed description was given. So thank you very much, and thank you all the participants, and thank you, Professor Zaman.
Thank you, sir. Also to you, Bodiuzzzaman sir. आपने salam dilam, sir.
Thank you. At the chamber time, you have joined us, spoiling your chamber. So thank you very much. You have joined us. We are so proud. Thank you very much.
Professor Tuhin Hoque, madam, you have huge experience in dealing with patients, complications, and everything with acute MI. If madam is with us, we can give some focus some light.
practical life, I like to congratulate both the speakers that for a very elaborate discussion and all the points that discussed regarding complication. As we are doing echocardiography, all the complication we are facing every day, like ventricular septal rupture and aneurysm. So it's our daily routine life. After MI, when there is complications, as you know, that Heart Foundation is a referral center. So every day we are we are observing the complications. I will request all the medical officer, please auscultate it. If you auscultate, as Farhad Jamal pointed out, the murmur, the type of murmur, we'll understand what is ventricular rupture, and when there is a papillary muscle rupture, the murmur of VSR and MR is different. So by cautious and very sincere auscultation, you can differentiate, and then you will refer for echocardiography. The doctors in the system, they can try themselves, and for confirmation, they can refer to the specialist. And I also like to thank Professor Mustafa Zaman, as he pointed the importance of RV function and importance of echocardiography for looking at RV function, because RV function is very easy to diagnose by echocardiography. So I like to congratulate everyone. Thank you.
Thank you, madam. Thank you.
I don't see Nazir sir here. Fazila madam, I also don't see her in the gallery. So I think it's already 9:30. Dhiman sir, Ashok sir, I think we can end. So I fondly remember the very helpful Mustafa Zaman Babul Bhai during our therapy days. So today also, yesterday when I called him, he immediately agreed. Though it was his very busy chamber time, he immediately agreed to be with us, and he also thanked our authority, Fazila madam, everyone for inviting him. I must mention that. Thank you, Mustafa Zaman, Professor Mustafa Zaman. So let's end it here. It's already 9:30. Thank you very much, and good night.
Thank you.